Yeah. One second. See here. And, 1, 2, 3, 4, 4. Let's give it another minute or two. Nice weather this weekend, eh?
Oh my gosh, it was so nice.
Yeah.
Well, one day. Saturday was
Yeah, Saturday was pretty
scary.
horrible, but Sunday was nice. Yeah. At least it wasn't cold.
That's very true.
Okay, I guess we'll get going. All righty. Okay, this very nice cardiologist in France has been emailing me with questions about cases, and he sent me this tracing, which is, according to him, this represents the electrocardiogram of a newborn who had a prenatal diagnosis of fetal flutter, which was treated, and the mom apparently was treated with flecainide and digoxin. So my question to you is, what is the diagnosis and what is the treatment? And I apologize to those of you who do not speak French to read the top of this tracing, but it's nice of Dr. Quizad to send us this tracing. So we ask, why don't we ask our neonatologist, Dr. Madali, if she has any thoughts on what she's looking at here?
Um,
Good morning.
Good morning. So
Can't
I
stop
do
writing.
see the, yeah, sorry, good morning. I do see the P waves
Mhm.
as a flutter, like usually in the atrial flutter, we see the sawtooth appearance of the P waves.
Mhm.
So I do see that those many P waves which are in the form of sawtooth.
Now, where do you see that? Which lead are you looking at?
V5 and V6, they are more prominent. I do see them more.
V5 and V6. Be honest with you, I'm not sure I see it in V5 or V6. What do you think about V1? Is it clearer there? I think it is.
Mm.
You see that? We're
Yeah.
pointing with the arrow. So it looks like there's quite a few P waves, more P waves than there are QRSs. So let me ask Katoki. So Katoki, what is the atrial rate? And is this usual for somebody who has what's the normal atrial rate when someone has a newborn atrial flutter? And what do you make of this atrial rate?
Um, Good morning, Dr. Pass.
Morning.
I would think so for this atrial rate, it's around from 1 P wave, 1, 2, let's say 2.5 big boxes. Divided by 2.5, it's like around 120-ish is the atrial rate.
No, it's
And
faster than that, right? How
I'm
many
looking from
how many
I'm looking from
boxes from P wave right? These are the P waves here, right?
so I'm looking from 1 P wave to the other P wave. Okay, there's a dropped.
So it's about
It's like
240 milliseconds dividing them, right?
Yeah, so I see like 2.5 big box, around 2.5 big boxes
No,
from
it's
one
not two and
PV.
a half. It's not 2.5, right?
The-
Here's a P wave. And then here's the next P wave right after one box,
Okay, okay, okay. I was like counting it with the prior.
right? So
Yeah,
look at this, right? It's just a little bit more than one 5 box, right?
yeah,
So okay, we got to get that right because that's a critical component of making a diagnosis, obviously, is getting the heart rate right. So the atrial rate is like, oh, let's make up a number, 250 beats per
fi-
minute.
yeah,
And the ventricular rate, or 240 beats per minute. And the ventricular rate is essentially half of that, right? It looks almost like almost 2 to 1, but it's not exactly right because here we have, like, notice the relationship of the P waves to the QRSs seems to be changing. So it's not
yeah.
exactly 2 to 1. It's like 3 to 2 or 6 to 5 or something like that, 6 to 4, something like that. Anyways, um, 7 to 4. So what do you make of what is when a newborn has atrial flutter, when you're called to the NICU for a baby with neonatal atrial flutter, what is a usual atrial flutter rate in a newborn?
I would think it's a little more than it's around 300.
No, it's actually usually faster than that. What do we see? Ivana, do you have any idea what the normal atrial rate in a newborn atrial flutter is?
Good morning. Yeah, I think closer to 400 to 450 or so.
Yeah, it could be 400 or 500 beats per minute. And there's usually variable block. And remember, one of the great sort of rules of thumb is that when a baby has neonatal atrial flutter, the ventricular rate is often about 200 beats per minute. I wouldn't hold fast to this rule, but it's usually around 200. And we know that the more common forms of SVT, orthodromic reentry or AVNRT, would typically be closer to 300 beats per minute. So usually what happens in atrial flutter is you have an atrial rate that's very, very fast, like 400 to 500 beats per minute, as Ivana said. And here we have an atrial rate that's like 250. So it's substantially slower than what we would normally see in a newborn who has newborn atrial flutter. So, Katoki, any thoughts on why this atrial rate would be slower? Did they have the diagnosis correct? What do you think?
Looking at this EKG, looking at B1, I see a P wave QRS, and then uh uh yeah uh,
So again,
and
why is
then
we've already established that there are more P waves than QRSs, right? Here's a P wave,
yeah,
P wave,
yeah.
P wave, P wave, P wave. And it seems fairly fixed, the A to A rate. Don't see one here, but so the question is, why is this atrial rate, excuse me, it is fast, it's 250, but we've already established that 250 would actually be quite a bit slower than what we would normally see in a newborn who has atrial flutter. Why is it, do you think, that this baby's arrhythmia is a fair bit slower? I mean, it seems odd to be saying that this is a slow arrhythmia when the atrium is going at 250 beats per minute, but
So
it's about 150 to 200 beats per minute slower than we normally see atrial flutter in newborns. So what do you think is the reason for that?
is it because the baby the mom was treated with flecainide and digoxin
That's exactly
and
right. That's exactly right. So this is basically an example of somebody who is on two agents, which will both slow atrial flutter, but not necessarily terminate it. Okay, so you have this patient who has fetal flutter. And by the way, flecainide and digoxin are both very reasonable agents to be used in fetal life to treat it. And in fact, I don't know what the fetal cardiologist in this case thought was happening towards the end of pregnancy, but clearly they got the ventricular rate to slow to a degree, and that's probably a combination of both AV nodal blocking from the agents, but also a result of slowing the atrial flutter. Although remember that paradoxically, if you slow something that's going at 450 beats per minute to 250 beats per minute, you might actually start conducting faster, paradoxically, right? Because instead of having block in the AV node, you might actually be able to conduct at that rate. So paradoxically, you could slow the atrial flutter, but actually have a faster ventricular rate. In this case, there clearly was both an effect on the atrial flutter, but also on the AV node from these agents, causing both a slowing of the atrial flutter and a ventricular rate reduction to a range that's appropriate. So, okay, so now you have this patient in front of you. You can now confirm that the fetal cardiologist was correct, that this looks like atrial flutter. You're not 100% sure, right? What else could this be? Christina, you've been told it's atrial flutter, but remember, of course, that the fetal cardiologist is making this diagnosis without an electrocardiogram. They're basing it just on ultrasound appearance and counting atria versus ventricle beats and trying to come up to some diagnosis. Is there any other diagnosis this could be?
Good morning, Dr. Pass.
Good morning.
Could it be atrial fibrillation?
Well, it's not atrial fibrillation, right? Because in fibrillation, we would see multiple different P waves, right, of different morphologies. And it looks pretty much, if you look at least in this lead and in this lead, that the P wave from P wave to P wave is pretty much the same. And the P to P interval seems fairly stable. So, right, in atrial fibrillation, we have presumably multiple reentrant circuits all occurring at the same time, and you have very irregular atrial rhythm with different kinds of P waves, and sometimes you can't even see P waves. So it's not fib, but it could be something else. What else could it be?
It could be 2-to-1 block if we're having.
Right, it could be 2-to-1 block, but it's clearly not 2-to-1, right? Because we have notice that here it looks like 2-to-1, but then we have a P wave that is earlier, or I should say is on time, and the PR interval is much longer. So it's not exactly 2-to-1. But what about the atrial arrhythmia? Is there any other diagnosis other than, so we've said AFib is not likely a case. We think flutter is the most likely just because that's the diagnosis we have been given. Is there any other atrial arrhythmia that this could be? Can't be ORT or AV, can't be ORT because in ORT there must be one P wave for every QRS, and we see here at least 2 P waves for every QRS. Could it be AVNRT? Could you have AVNRT with 2 P waves for every QRS?
Yes.
Very rarely you could have reentry in the AV node, and the His Purkinje system conducts half as well as the atrium conducts and the AV node conducts. And so you could have 2 A's for every V, but the thing that gives the lie to that is this beat here, where the relationship of the P wave and the QRS changes. But if you take away this beat, you don't show that beat, it's conceivable that's what the case is, but that's very unusual. We see it almost only in, the only time I've really seen it that I've known I've seen it has been in the cath lab when we have a His catheter in place. We sometimes can induce atrial flutter with 2-to-1, but I don't really see that so much clinically, or at least if I haven't recognized it. Any other atrial arrhythmias that this might be?
You say ectopic atrial tachycardia?
Yeah, this could be ectopic atrial tachycardia, right? This could just be a primary atrial tachycardia, and that would go more with the rate, right? In EATs, we don't usually see rates of like 400. This would be a not unusual heart rate, a little fast for EAT in a baby, but not unheard of. It could be EAT. Okay, so you now have in your own mind decided that this is either atrial flutter, which is what the fetal cardiologists have told you it is, or it's ectopic atrial tachycardia. We've ruled out AFib, we've ruled out AVNRT, we've ruled out ORT, we have ruled out pretty much everything except for that. Could be 2-to-1 AVNRT, but we kind of ruled that out because the relationship of the P waves to the QRS is changing, as demonstrated in this beat here. So is there a way? So what would you do now for this patient? So those are your two options. You're in the NICU. The NICU wants an answer, and they want to get this kid out of this arrhythmia. So why don't I ask Dr. Marshall? So now you have your differential diagnosis. You think the fetal cardiologists are right, but you're not 1,000% certain. Never trust anyone, or as Ronald Reagan said, trust but verify. So how are you going to, what's your next step? How are you going to treat this or diagnose it to get it right?
My first question is how old is this day of life 0 and how's the baby otherwise?
Fair questions. Day of life 0, yes. Baby looks fine. Very cute little baby.
And blood hemodynamically stable?
Is hemodynamically stable for the time being. You have not yet obtained an echocardiogram, but the child has good perfusion, is 3 kilograms, let's say.
Okay. So I mean, first, if you're if the baby is unstable or if there's any concerns, I mean, I think the answer is the same either way, but you would do direct DC cardioversion.
Okay. And if you were going to do DC cardioversion, how much energy would you give? Would you give it synchronized or asynchronous? Would you sedate the child or not sedate the child? How would you practically do this? So you're there, you have a very attentive nurse and neonatologist. They're on bated breath for your recommendations. So how are you going to instruct them to do this?
So first, for the logistics of the dose, you would do 0.5 to 1. I don't know what the smallest with how 0.1 to 5 joules per kilo. I don't know how small it allows you to go on the machine.
I think you could give exactly the right amount. So let's say, so you're going for 0.5 to 1. So I'll just tell you my own bias. Although I wrote a paper in which we demonstrated that the average person, I think, for SVTs only needed 1/3 of a joule with biphasic defibrillator, which is the only type that's presently available.
Well, that'd be 1 little joule then. That'd be kind of nice.
Exactly, but just a little joule. I actually normally give 1 per kilo because I sort of feel like I don't want to risk the possibility, because the response to the cardioversion will be useful information in cinching down the diagnosis, and I don't want there to be a possibility that I just didn't give enough, that it would have worked if I had given a real dose. So I would recommend, as a general rule, that for SVTs, whether it's a primary atrial arrhythmia or a reentrant atrioventricular rhythm, I would probably recommend that you give 1 joule per kilo. Okay, so we've decided we're going to give 3 joules. What else do you need to do?
And then you want it to be synchronized to the QRS to avoid R on T phenomena.
Okay.
And then in terms of the sedation question,
and how would you, if I might step back, how would you do that on the defibrillator so that it is synchronized to the QRS? What lead are you going to tell the defibrillator to use to synchronize?
Ooh. Lead 1 or 2. I'm not sure of the answer to that actually, but I'm going to guess lead 1 or 2.
So it turns out if you ever look at external defibrillators, there is usually a cable that you could put ECG leads on the patient. We virtually never use that, though.
Sounds like when we've done that, I've never even.
We almost never use that. Most of the time, we just synchronize off the QRS that's obtained from the actual pads themselves.
Right.
So the pads are the lead. And I don't know what the right answer is, if it's better to use multiple surface leads, but interestingly enough, the filtering on defibrillators, external defibrillators, is usually excellent. It's sometimes shocking to me how you can make a diagnosis on a defibrillator device on the little EKG printout that you're looking at just on that little screen is clearer sometimes than what we see on the EP recording equipment. And it's something to do with the way in which it's filtered nicely. But usually you would use the pads. That's the most standard one. But you could
Okay.
actually, if for whatever reason you didn't feel you were getting a clear QRS or it wasn't synchronizing properly, you could, and remember that the sync is demonstrated on most defibrillators by a little dot over each
Yeah.
QRS.
Hmm.
Okay, so you've put the pads on, and you've put it in synchronized mode, and you've convinced yourself that you're synchronizing. You know you're going to give 3 joules. Now, are you going to sedate this child, or are you going to just shock the baby? It's just a single 3-joule shock.
If they are, which they're not, but if they were unstable, I would without sedation. But it sounds like if the baby's stable, I think it's reasonable to give them some like light sedation for it.
Yeah, I mean, I think what I would say is everybody deserves sedation unless you
Yeah.
are conscious.
Yeah, like unless
so-
it's an absolute emergency. But
Right. So this is a baby who we would give, I make this number up, but maybe 0.1 per kilo of morphine or
Mhm.
1 mic per kilo of fentanyl. I don't know, Ivana
Mhm.
Capin,
Could
ICU
you do
doctor extraordinaire. What would
Versed
you
or
give?
something?
What would
I'd
you?
probably give a little bit of fentanyl. I feel like the 0.1 of morphine wouldn't really touch the kid.
Okay, so you would
And
give
just,
like 1 mic per kilo of fentanyl or 2, or what would you
I'd
do?
probably start with 1 and see how they got on.
Okay, all right. So you got to be careful though with the fentanyl, right? Because you could get rigid chest, and you do not have an airway in this patient.
Mhm.
Yeah,
Uh,
but you would just make sure you could, I mean, worst case, you would just sedate, paralyze, and intubate them.
Right. So if you had rigid chest, Ivana, since we're asking, since I invoked rigid chest, how would you treat that? So you've given 2 mics, you've given 2 per kilo. Baby's very sedated, but is also not breathing. You bring the bag over, and you can't actually ventilate the child because the child has a rigid chest. What would you do at that point?
Well, I would paralyze them. I'd
Right.
probably have someone call a dart while I was just going for a direct laryngoscopy view.
For
And
those
then,
of us who are not familiar, the term DART means what?
sorry, it's an emergent airway team that comes to bedside, and it includes ENT and anesthesia. So
I see.
anytime you're at risk, it's always safer to call them.
Right. So, first of all, first thing to say is I certainly agree you should sedate people. And, we've discussed in this conference a few times now people who've unfortunately been cardioverted awake, and it is a terrible thing to do to somebody. And just because babies don't talk and won't complain doesn't mean we should do that. So, yes, you should sedate them, but right, when you paralyze somebody, I'm sorry, when you give somebody fentanyl, there's always a small risk of rigid chest. Usually, right, correct me if I'm wrong, it's when it's administered very, very rapidly. Isn't that really when you get that risk, Ivana?
Yeah, I've only seen it once, but it was under those circumstances. I mean, usually we give fentanyl fairly quickly, but you can always run it kind of over a
Right.
couple of seconds or minutes, sorry.
Yeah, when I was a fellow, some of you may have heard me tell this story, but when we would be on call in the cardiac intensive care unit at night, it was you were allowed to, they had a policy at Boston Children's, I don't know if it's still true, that they would re-intubate everybody who came with an oral intubation to a nasal intubation. They had a belief that nasal intubation was more stable and less likely to dislodge. And so that would be something that would be done after rounds. And if you were the on-call doctor, you had the pleasure of doing it, and you would typically do it with one of the attendings. And sometimes there might be as many as 2 or 3 infants in an evening that you had to re-intubate. And the thing that I remember Dr. David Wessel, who some of you may remember was our visiting professor a year or 2 ago, he did this with me, and he demonstrated for me rigid chest in a patient where he intentionally pushed the fentanyl fast, and I was bag mask ventilating, and I could not ventilate. And then he gave a dose of succinylcholine, and the patient was paralyzed, easy to ventilate again, just to demonstrate to me that it was a real thing. I wouldn't recommend you do that, by the way, but he's an experienced anesthesiologist and intensivist, so he felt comfortable doing that. Okay, so you've given so Molly, you've phoned a friend, Dr. Capin. She's recommended that you give 1 mic per kilo of fentanyl. The child seems pretty chill. You have your 3 joules ready, you're synchronized. Anything else you need to do, or should you just go whammo and just deal with it?
Make sure to announce to everyone that's what we're doing and that we're clear from the baby.
Okay, right. So you're going to clear the bed. You're going to cardiovert, and what I was told from Dr. Quizat, I don't have the post tracing, is that the baby converted to sinus rhythm.
Great.
And so the child is now in sinus rhythm. So what does that tell you about the possibility that this was EAT, Molly? Does that help you in ruling in or ruling out that diagnosis?
I would think it's less likely and more suggestive of flutter with that
Right.
change.
Right. In fact, EAT should not terminate with
Right.
cardioversion, right? Because cardioversion is great for reentrant arrhythmias, such as atrial flutter, not so great for automatic type of
Automaticity. Yeah.
arrhythmias like EAT. It's the same reason why we would not cardiovert somebody in jet.
Mhm.
It should not do anything. Okay, so you've now cardioverted the patient. They're now in sinus. So now Dr. Madali is asking you, well, what do you want to do? This mother was on flecainide and digoxin. Do we need to treat this infant? And what do you think?
So I feel like if the mom, I'm not fully sure on this, but if the mom had it if baby had it fetally, I feel that you could go onto oral like antiarrhythmics. But I also like, because I don't know, like for babies that have had it without having it fetally, I know that if they are cardioverted, like we can watch after to see if they go into it again. If they do, then treat like pharmacologically, I mean.
Now, why is that? I agree with you. Why do we not usually treat atrial flutter in the fetal, I should say,
In the
newborn
new
atrial flutter?
postnatal, yeah.
We usually cardiovert, and we often will just observe and not start therapy. Why? What is that based on? Why do we do that?
My understanding is that's based on data of like the natural time course that it's common in the newborn period and self-result like is self-limiting in terms of gets better as the baby grows.
Yeah, I think the data suggests that about 75 to 80% of these patients will not recur and will off of therapy.
Yeah.
So based on that, and the longer you go without flutter as a newborn, the less likely it is going to recur. So typically we would cardiovert a baby with neonatal flutter, and we would just observe that patient for a few days. And if there was no recurrence, we would just monitor as an outpatient. There isn't a right answer, by the way, to whether somebody who had a fetal diagnosis of atrial flutter ought to be treated beyond fetal life. I probably would take an in-between stance and maybe treat for a short period of time. I would
Then
probably
trial off.
Yeah, I probably would not, as you all know, we are always a little afraid of flecainide in the baby because of the issue of how hard it is to make a solution and the possibility that babies can get overdosed with it, particularly towards the bottom of the bottle, because of concerns that it could, if it's given around the time of feeds, it'll be somewhat deactivated, and then patient could be getting, varying doses of flecainide just based on what's in the stomach at the time of the dosing. So if we don't need to use flecainide in a baby, my general preference would be not to use flecainide in a baby. So what I might do is take an in-between step and consider continuation of digoxin in the baby temporarily. Honestly, I would probably be mostly treating myself and not the patient. But I definitely, though, feel like if there's a baby who had ORT or AVNRT in utero and it was very close to delivery, I would usually treat that patient because I'm not sure why we would, because the natural history of that is that it's going to take months to resolve, and it may not even resolve, as opposed to atrial flutter, where even the bad atrial flutters in newborns that require aggressive medical therapy, even those will resolve by 4 to 6 months of age in the vast majority of cases. So but ORT, for example, could persist. And so if somebody had ORT on week 37 of gestation and then is born on week 39 and is not in ORT, my personal preference is to treat that infant and not, because I don't really know what demonstrating 2 days of no tachycardia means in terms of the likelihood of it recurring. And we do know that in newborns, there's a reasonable chance it's going to recur at least in the first few months of life. So I would normally treat that arrhythmia if it were fetally diagnosed, but I would not treat flutter usually. But if somebody was in flutter for a long time, I mean, presumably if the mother was treated with both flecainide and digoxin, somebody thought that this was a difficult to treat flutter, and as we're on two different agents, both fairly aggressive. So anyways, that would be my bias. If somebody said they'd like to watch and wait, I certainly don't think that's wrong. It's perfectly reasonable. But I probably would lean towards treating it. Any questions about this?
Yeah, I have a quick question. So with regards to the prenatal diagnosis of atrial flutter, would flecainide be your drug of choice for this type of patient? And then it seems as if at least this patient never really got out of flutter, despite being on the two agents. So anything else you would have chosen or done differently?
I think actually there's a recent paper that came out, a statement from the Fetal Heart Society on the treatment of fetal arrhythmias. I'll look for it this week, and if I find it, I'll send a copy to everybody on the call. But I think flecainide is actually, I don't want to misspeak, but I'm pretty sure that flecainide is their first line for flutter. And for a lot of different arrhythmias, it has good penetrance to the through the placenta to the fetus. And so, yeah, I think flecainide, sometimes people will use digoxin, has to be given in very high dose. The only thing I would say about that, I think it's people are moving away from it because it's not as generally effective. But if it's used, it must be used in very, very high dose to the mother in order, the key thing is the presence or absence of hydrops in the fetus. When a fetus has hydrops, it's very difficult to fetally treat the baby, treat the fetus through the mother, because the drugs don't have as good penetrance. So you really want to sort of, if you're fairly certain you have an arrhythmia, you want to attack it before the patient has hydrops, because it becomes much harder to manage it. I often tell this story. Early in my career, there was a patient who had been treated with actually with orthodromic reentry, and was in SVT in utero for a number of weeks. And the outside cardiologist, who was not really a fetal cardiologist, was treating with like beta blockers and low dose digoxin. And by the time the patient was referred to Columbia at the time, there was a very large pericardial effusion, and there was developing hydrops. And we were at like 23 weeks and 3 days. There was like literally 3 days before legally the pregnancy could be terminated. And the mother was very insistent that I explained to her whether or not A, I could get the child out of tachycardia, and B, was there going to be an injury to the brain as a result of this low cardiac output state. And I, obviously, I couldn't answer definitively either of those questions, but I told the mother that I thought it was likely that we would be able to stop the tachycardia and that the fetus would probably be fine, but that, I couldn't guarantee that the child would be fine. And so she was really on the fence about whether to terminate this pregnancy, but ultimately, when it came down to 23 weeks and 6.5 days, she decided, based on my optimism, to continue onward with the pregnancy. And a day later, the tachycardia broke. And the hydrops resolved. And amazingly enough, that child ended up growing up and spent a month with me as a high school student in pediatric cardiology, and is now a pre-med at the University of Miami, and almost died or almost had his life terminated in utero because of the tachycardia. So it's a nice story, I guess, but In that case, though, I'm almost certain that I did treat that child for about 6 months with antiarrhythmic therapy. That's the other interesting thing, which is, traditionally we've treated for a full year after when somebody is born, but increasingly there's more and more papers demonstrating that probably that was too aggressive, that there isn't really a statistical difference between treating for 6 to 9 months versus 12 months. So I have always generally, if somebody is well controlled as a newborn, I will weight adjust my medications till about 6 months of age and then allow child to outgrow the agent so that whenever I stop it, I already have a little bit of evidence that the medication is no longer necessary by being on either a low dose or even a subtherapeutic dose when it's stopped.
Thank you. And
Okay.
then this is also I don't know if this is a totally out there question, because I can't really rationalize it in my head, but if you had a very refractory fetal tachycardia, is there any way you could shock the child while in utero, obviously the mom as well? Would that do anything depending on where you place leads? Has that ever been done?
I don't know the answer to the question of whether it's ever been done, but it is not done. And I don't know the exact reasons, except to say that probably it could induce early delivery, or there's probably a lot of obstetrical reasons why that's not a good idea. I don't know what it would do to the uterus. Seems like it would be bad to send pulsating energy to a woman's uterus when it is actively pregnant with a human being inside of it. I might be wrong. In other words, I also don't know how you would deliver it directly to the heart,
Right.
not to the right. You're just basically electrocuting the uterus and the
Right.
entire fetus. So
Mhm.
it seems intuitively like that would be a bad idea. I'm sure there's a better answer than I've just given you, but it's not done. No, no.
Thank you.
I mean, I guess you could do a fetal intervention and maybe pace the heart, but again, fetal intervention carries its own very substantial risks to the fetus. And actually, if you listen to the podcast a week or two ago, we talked about fetal aortic valvuloplasty, and in that series, there was about a 4% fetal demise with fetal intervention, and that's in the hands of a very, very experienced group that's been doing it for 20 years. So we would never, at least in 2024, we would not recommend that for this. And I'm not aware of anybody who's done that. Now, there used to be, and still is done, that maternal fetal medicine specialists have given intramuscular digoxin and amiodarone to fetuses. That's been done for a long time. That can be very effective as well. But I'm not really sure what the indications are for that. And I think in general that is falling out of favor. But I don't know that literature very well, to be honest.
Thank
Okay,
you. I'll look into it.
I think at this point we're going to stop. I hope everyone has a good day. Thanks for joining.
Thank you.
Take care, everyone. Bye.
Thanks.